Hello, scholars. My name is Dr. Karis Dillon, and the goal of this channel is to make academic subjects easier to understand. In the last video, we looked at catatonia. In this video, we're going to take a look at bipolar I disorder, so let's begin. Now, bipolar disorders are not the same as depressive disorders. If you were to open the DSM-5, the book, you would find bipolar disorders in between schizophrenia or psychotic disorders and depressive disorders. This is because they share some characteristics of both, but are not the same as either disorder. The bipolar disorders that we'll cover in this series are bipolar I disorder, bipolar II disorder, cyclothymic disorder, and substance medication-induced bipolar disorder. Now, in this video, we're just covering bipolar I disorder. The red covers that you see on the outside of each video show you that these are bipolar disorders. In the past, we used to call bipolar I disorder manic depressive disorder, but this is no longer the case. In the past, people used to believe that psychosis stayed forever with bipolar disorder, and this is simply not true. With proper medications, individuals can keep most manic episodes from arising. It is true that most people with depression have some pretty bad depressive episodes if they have bipolar I, though, and that they tend to struggle with this on and off through the rest of their lives. In order to be diagnosed with bipolar I disorder, an individual has to have at least one manic episode or more. A manic episode is going to be different from a hypomanic episode, so we'll talk about that in a second. But a manic episode is a period of time that generally lasts about a week or longer, where an individual can have goal-directed activity and seems to have this endless energy. Their mood can be anywhere from elated to irritable to hyper-focused on something or just expansive in general. Along with the difference in mood as well as increased energy, there has to be 3 or more of the following symptoms. 1, an increased self-esteem or sense of grandiosity. Now, a sense of grandiosity is believing that you're Superman or that you can do things that other people cannot do. 2, there's less of a need for sleep. This individual can feel rested after only 3 hours or so of sleep. They may be extremely talkative or pressure others to keep talking along with them. Number 4, their ideas may shift quickly from one subject to the next. They may not be able to keep their focus just on one subject. They may have their attention easily drawn away towards something else, even when they're poring over something that they feel is vitally important to be talked about. Their goal-oriented behavior can be social, school-oriented, work-oriented, or sexually focused. Much of their time, their behaviors usually are purposeless. The behaviors and activities they take part in can be dangerous for themselves and for others as well. They may make large purchases with very little money, such as using a credit card, and they'll just buy all the way through the credit card. They may make foolish business investments, have sex or some form of sex with strangers, or buy unneeded things. Generally, the person's mood is so hard to get along with over a long period of time that they suffer socially, academically, in their work, or may attempt to harm themselves because they're in a psychotic state. Much of the time, manic states can lead to hospitalization. The manic episode is not because of a drug or substance the person took or a medication or because of a medical condition. Now, this is a good place to note that physicians may try different people on an antidepressant because they feel that they have major depression. And what can sometimes happen is a person can have, and I don't want to say this to scare anybody, but there are a few situations where a person can have a full manic episode given a certain antidepressant. And it's not a certain antidepressant that sets everyone off. Certain antidepressants can set different people off. And when that happens, we know that that individual has bipolar I. And this is something that we just came on as a scientific community. We just learned it as we tested and went along. There isn't any way to test for bipolar. So this is just one of the things that can happen kind of by accident where we find out someone has bipolar. Okay, so hypomanic episode, that is a little bit different. You're going to notice that the time period is different, whereas manic episodes were a week or longer. A hypomanic episode is about 3 to 4 days, or essentially less than a week. This is kind of the same mentality where the individual has increased energy, has an activity that they're extremely focused on, and may have an irritable mood. This mood will typically last throughout the majority of the day. During this period of a couple days in this hypomanic episode, they have to have 3 of the following symptoms. The individual has a significant increase in self-esteem or a feeling of grandiosity. So you've heard that one before. The individual will not need as much sleep as they usually do. The person is more talkative, will want others to keep talking with them. The individual's thoughts will race and the ideas will jump from one thing to another. The person's focus may jump to something insignificant right when they're talking about something that's very important to them. So we're seeing a lot of these same symptoms, but we can say that they're just not to the level of a manic episode. They'll want to take part in things that are goal-oriented, either through a relationship, academics, through work, or in a sexual manner. They can go on these buying sprees. They can take part in sexual relations with somebody they don't know. They can gamble. But usually the amount of what they're doing is not as desperate as what would happen in a manic episode. So for this, family members will notice that there's behavioral changes, attitude changes, and experiences of the person that are not as the same as what the person normally does. The changes in mood and activity are noticed by those that wouldn't usually notice those changes, like maybe an acquaintance across the street may notice different changes. The behavior and changes in mood are not so disastrous that they end a relationship with somebody, and normally a hypomanic episode, they'll not end up in the hospital because of it. They don't have the psychotic features, and there's the difference right there. They don't have the psychotic features of a manic episode, so it's not a full-blown issue. These hypomanic episodes cannot take place because of a substance, a medication, or a medical condition. To have a major depressive episode involved in the bipolar I type for diagnosis, they have to have 5 or more of the following symptoms for 2 weeks, which is a change from what they normally are. At least one symptom has to be a depressed mood or a loss of interest or pleasure in what they normally do. Number 2, the depressed mood continues most of the day, almost every single day, and can be reported, excuse the sirens in the back, by the person themselves or by others. The individual does not feel pleasure from things that they did in the past with nearly all activity and nearly all days. The individual will increase or decrease their body weight of at least 5% because they don't have an appetite or because they have a huge increase in their appetite. The individual will suffer from insomnia or hypersomnia every day. The individual will move more slowly and have feelings like they haven't rested at all. They may have fatigue or loss of energy each day. They may have feelings like they're worthless or feeling guilty for everything that they're doing or just for existing. They may have trouble finishing things or being able to concentrate. It may be hard to make decisions. They may think continuously about death, not just a fear of dying, but actually making a plan to kill themselves. Their symptoms cause problems in relationships, in academic work, in physical work, and in other areas of life. These depressive episodes are not because of substance abuse, medication, or a medical condition. For bipolar I disorder, an individual has to meet the criteria for having at least one manic episode. This is a full-blown episode with psychotic features. The manic episode cannot be better explained by a diagnosis of schizophrenia, delusional disorder, schizoaffective disorder, or any other psychotic disorder. Now, the biggest factor that makes these symptoms bipolar and not psychotic disorder is the presence of a major depressive episode, an MDE. The major depression that is associated with bipolar disorder is often deeper and hangs on to a person like no other. It tends to come in waves and acts differently than other major depressive episodes. So it's important when diagnosing bipolar I disorder that you specify, does the individual have anxiety and do they have distress? Also specify with mixed features, do they experience both depressive episodes and mania at the same time? That's called mixed features. With rapid cycling, 4 or more mood episodes within a 12-month period. So if they are having 4 or more mood episodes within a 12-month period, they are having rapid cycling. We'll want to specify that. Also specify with melancholic features, which means not feeling pleasure from activities. Also specify with atypical features, features that are not generally seen with this disorder. As an example, I was not diagnosed with celiac disease until 32 years old, and it was because I was overweight. And usually people with celiac look malnourished and look very, very tiny. And that was not me. I had an atypical feature of celiac. All right, with mood congruent psychotic features, you'll want to specify that. What that means is the delusions and hallucinations impact your mood and beliefs. So if you're having dark delusions or dark hallucinations, that's impacting your mood. Of course, you can also have with mood incongruent psychotic features that your delusions and hallucinations are not impacting your mood. Then, of course, specify with catatonia. Are you having stupors? Are you rigid with your structure? Do you have kind of body postures that are abnormal? Then you'll want to specify with peripartum onset, shortly before, during, and giving birth. Are we seeing anything that's coming up during those I shouldn't say quick, but during those times? And then with seasonal patterns, are you seeing a difference with each of the seasons? So here are some other features of bipolar I in regards to an individual's mood. Sometimes a person in a manic state will be especially cheery and start a conversation with a stranger for no particular reason. Now, this is not normally something that we'd be concerned about, but when it's not a part of a person's habits or behaviors on a regular basis, it's just something to kind of keep track of. Generally, most people with bipolar I will have a mood that's irritable rather than elevated, particularly when that person wishes to do something and then they're denied to be able to do it. It's very difficult, and specialists will hesitate to diagnose children with bipolar I. For those children that do have bipolar I, their manic episodes can look silly or goofy, especially in normal situations. But when it comes to context where their silliness and goofiness is extremely inappropriate, that's what makes it easier to know that something is not going right. When trying to diagnose a child with bipolar disorder I, and usually they just don't do it, they wait till they're 18, they will first try to look at baseline behavior. How does the child react given most situations? It is quite normal for those with bipolar disorder I to engage in many projects at the same time that may overlap one another. Usually, the individual does not have much knowledge about how to do the project. They may try to work on the project in weird hours of the day and night. An individual will believe themselves to have great talents beyond others, and these can reach delusional proportions. They may decide that they're going to write a book or speak in public on a subject they may not know anything about. Usually, a decreased need for sleep or a lack of sleep can sometimes bring about these manic or hypomanic episodes. Well, this was definitely a big one for sure, but I would say there are a lot of misunderstandings when it comes to bipolar I, and our next video, of course, is going to be bipolar II. So I will try in that video to kind of distinguish, hey, remember in bipolar I, this is what this said. This is how it's different from bipolar II. And This is according to the DSM-5. I always get mental health students that tell me it's the other way around, but I get my information directly from the source, the DSM-5. So if you have any problems with the way that information is brought forth, I would definitely write the DSM-5 and critique them and the way that they put things together, because I don't have a say. I don't go to the conferences currently, so I wouldn't have a way to bring that information to them. But I would definitely say write a letter or something. Thank you so much to everyone that is appreciating this information. I hope that it helps you learn, for whatever reason you're learning about mental illnesses. Some of you have told me that you're doing it for a psych class. Others just have interest. And some of you are becoming therapists or are working in clinical psychological hospitals and clinics. So I'm so very, very proud of you, and just feeling blessed and amazed that I can kind of help you in that process, even though I'm not your teacher and am in front of you. So I really appreciate that, and keep passing along all this info. I think the more that we can pass on knowledge and facts and helping to decrease taboo, the better off all of us are going to be to help make our world a better place. Thank you, and I will talk with you soon.